I'll be saying about acute diarrheal disease. Acute watery diarrheal disease. What are its causes? What are its causes, pathogenesis, clinical features, complication, assessment, and management? I will be discussing here in a child with a severe dehydration. First, major contribution. This is a diarrhea is a major contribution for under 5 mortality rate. So this is important. This is important to discuss. So for first diarrhea we can classify as acute diarrhea, persistent diarrhea, and chronic diarrhea. We call it as acute diarrhea when it occurs occurs for a duration of less than 7 days. If it's more than 14 if it is till 7 days, it's acute. If it's more than 14 days, it can be persistent or chronic. If it's more than 14 days and it's up to months, then it's chronic. And when which is non-infectious cause is a chronic one. But when more than 14 years, but infectious cause is persistent diarrhea. Acute diarrhea less than 7 days, which is an infectious cause. Persistent diarrhea is also infectious cause, but more than 14 days. As chronic diarrhea, more than 14 days up to months, but it's because of non-infectious cause. This is very important. Like malnutrition and all those like these things, especially in malabsorption disorders or gluten sensitivity metabolic error. Gluten sensitivity disorder are there. You have to not eat gluten rich food where gluten is not metabolized, example barley and all those things you should not eat. Then coming for acute diarrhea, most common cause is rotavirus in children. Next, coming for the definition of the diarrhea, passage of more than 3 loose stools or watery stools in a 24 hours, that is within that one day you have to pass 3 loose stools. This consistency is more important than the frequency. If you're not passing 3 stools also, but like it should be loose stools like watery stools. Number is not important, frequency is not important, the important is consistency. Then coming for the what is dysentery, difference between the diarrhea and dysentery. Dysentery which contains blood, a diarrhea with visible blood with fever or tenesmus. These are associated with the dysentery. How you will differentiate between diarrhea and dysentery is these things. Now coming for the etiology or cause, most common virus I already told, rotavirus. It may be infectious cause because like acute diarrhea may be because of infectious cause or non-infectious cause. Infectious cause it may be bacteria, vira or parasite. In virus you have rotavirus, astrovirus, adenovirus, calcivirus and coronavirus. 2 C's, calcivirus and coronavirus. 2 A's, adenovirus and astrovirus, and 1 R, this is rotavirus. And it can be bacterial cause. Bacterial may be E. coli, Shigella salmonella, Vibrio cholera, E. coli, and Bacillus cereus. These may be bacterial organisms which causes acute diarrhea. And coming for the parasites, we have Entamoeba histolytica, Ascaris, hookworm, strong alerts, all worms, hookworm, roundworm, tapeworm, all those you can write. And then coming for non-infectious cause, it may be because of kwashiorkor, which is a protein energy malnutrition in children under 5, and celiac disease or pellagra. 4 Ds are there: diarrhea, diarrhea, dermatitis, lastly death, and all those. This in pellagra also you'll see diarrhea. And what are the risk factors who will get diarrhea? Means if they are malnutrition, when there is a reduced gastric emptying, or immunodeficiency. In immunodeficiency, these organisms can attack very easily, so they'll get diarrhea. In this page we have discussed what are the types of diarrhea: acute, persistent and chronic, based on the duration and the infectious or non-infectious. Definition of diarrhea and dysentery. Etiology, it may be infectious or non-infectious, and infectious virus, parasite and bacteria, and risk factors. Now we will discuss other things. Pathogenesis, first initially we'll see what is the mode of transmission of these organisms. These organisms enter through fecal-oral transmission. Through contaminated food and water they'll enter. We may ingest toxins, or we may directly ingest organisms. If we are ingesting organisms, they will undergo in the bowel, they'll colonize and they'll elaborate, and then they'll produce they'll produce toxins, or we may directly ingest a toxin which binds to the enterocytes, this intestine cells, and then they produce they increase the concentration of the intracellular cyclic AMP and cyclic GMP and calcium. which will activate further, which will activate the protein kinase enzyme, which protein kinase enzyme which helps in which alters in the transporter proteins and ion channels, and everything is secreted into the lumen of the gut, like sodium, potassium, everything, like all ion channels are like altered. So these ions will be secreted into the lumen. Along with sodium, water is also drawn inside the lumen. So you will be excreting watery stools or loose stools. This is all about the pathogenesis. First, the organism or toxin is ingested by us. Then if the organism is ingested, they'll undergo colonization, elaboration, and they'll bind to the enterocytes. They'll produce toxin, which toxin binds to the enterocytes, and it increases cyclic intracellular cyclic AMP, cyclic GMP, and calcium, which activates the intracellular mediators like protein kinase and alters the ion transporter or protein channels or ion channels, which causes diarrhea. Next, now coming for the clinical features. Now all fluid is lost. Fluid in the body is lost. So what you will see, anterior frontal alley, which will close at 1.5 year or 18 months, will this will be open. So it's a CSF, we can feel CSF here. If we complete CNF CSF, like fluid is lost in the body, it will be sunken. So depressed anterior frontal alley. Altered sensorium because of loss of water content is lost, and blood supply to the brain is lost, and then altered sensorium. And then eyes will be dry, no water fluid in the body, so eyes will be dry and sunken. Dry mucous membrane, you will feel thirst because you are deprived of water, and you will feel tachypnea because less volume is there. You will do more work to supply blood to the body. Tachycardia and tachypnea will be there, and there is no volume in the blood, so blood pressure will be low, hypotension will be there, and you will feel, when there is a blood flow, you will feel warm. When there is no blood flow, sufficient blood flow to the terminal organs, everything will be deviated to the vital organs like brain and heart. There won't be blood flow to the periphery, so you'll feel cold extremities. And feel cyanosis because of decreased oxygenated blood, and then sudden weight loss because of fluid also will contribute to the this thing. Wet white, so you will feel sudden weight loss, and abdominal distension will be there. Then oliguria because renal perfusion will lead to oliguria, and loss of skin elasticity. Skin elasticity is contributed by the fluid, so you will lose skin elasticity. Then you got clinical features. Clinical features: depressed anterior frontal alley, altered sensorium, sunken eyes and eyes, dry mucous membrane, thirst, and tachypnea, tachycardia, hypotension, cold limbs, cyanosis, sudden weight loss, abdominal distension, oliguria, and loss of skin elasticity. This I explained you in one by one how it occurs. Now we will go for the assessment. How you will assess the diarrheal status, like dehydration status in the diarrhea or any fluid loss conditions like chronic vomiting, chronic diarrhea, or excessive sweating. In all those conditions, how you will assess the dehydration status of the child, you will see now. You can classify them into three categories like no dehydration, some dehydration, and severe dehydration. In no dehydration, the child will be active and alert, whereas in some dehydration it will be already irritated, whereas in severe dehydration there is no they can't act like anything because it is fully severely dehydrated, so it will be lethargy. Whereas coming for the percentage of the body weight loss in case of no dehydration is 5%, in some dehydration 5 to 10%, whereas in severe dehydration it will be more than 10%. 5%, 5 to 10%, and more than 10%. Coming for the eyes and tears, eyes and tears will be normal in case of no dehydration, whereas in some dehydration eyes will be sunken and tears will be absent, whereas in severe dehydration also tears will be absent, whereas eyes will be very much sunken. Now coming for a mouth and a tongue, mouth and tongue will be normal in some no dehydration, whereas in some dehydration it will be dry, whereas severe dehydration it will be very dry. Coming for a thirst will be normal in case of no dehydration, whereas in some dehydration it will be severe thirst, whereas in severe dehydration they can't feel anything, so they are unable to drink, so they won't be thirst here. This is important point you need to remember. Next, coming for the skin pinch test. Skin pinch test means you will be pinching the skin over the dorsum of the fingers, and then you will see how fast it will goes back to its position. It will turgidity. If it recoils within less than 1 second means there will be no dehydration. If it recoils equal to 2 seconds or less than 2 seconds, but more than 1 second means some dehydration. More than 2 seconds means it's a severe dehydration. Less than 1 second, equal to or up to 2 seconds, or more than 2 seconds. no dehydration, some dehydration, and severe dehydration. And coming for the anterior frontal layer normally it will be normal level, whereas in case of some dehydration it will be depressed, whereas in case of severe depression it will be very much depressed. Coming for the treatment for so no dehydration, you have plan A where you will be giving a home available fluids only. What are the home available fluids I'll be discussing further. Whereas in case of some dehydration, you will be going with the ORS, WHO ORS, which is low molecular ORS. Whereas in case of severe dehydration, you will be going for direct IV fluids, because there won't be any time for the oral intake and then absorption and all those. So I'll be directly giving the IV fluids. So in this page you learnt how you will assess clinical features and pathogenesis of the diarrhea. And now we will see what are the complications of diarrhea. If diarrhea occurs, what are the complications you need to face anta we'll see. Complications, it may cause convulsions because of diarrhea. These convulsions may be because of electrolyte or metabolic imbalance, or because of infection, or because of direct dehydration. In diarrhea you feel dehydration is the most common complication. Whereas in electrolyte and metabolic imbalance, it will leads to acidosis. Whereas in electrolyte imbalance, glucose will be reduced, sodium will be reduced or increased, or whereas hypokalemia, whereas potassium is decreased. In infections can occur because of decreased, because everything is going out, diarrhea. So immunoglobulins are also going out, no energy to form immunoglobulins and all those. So you will be recurrently having fever, infections like meningitis and encephalitis. Then dehydration, cerebral venous thrombosis and sagittal sinus thrombosis. These are the complications which leads to the convulsions with diarrheal disease. How you will manage? For management, you have plan A, plan B, plan C. I already told, for plan no dehydration you have plan A, some dehydration you have plan B, whereas severe dehydration you have plan C. Treatment plan A include, this is for no dehydration. You have to you have to do three things, you have to increase fluid intake, and then you have to continue for feeding in order to prevent malnutrition, breastfeeding should be continued, and you have to watch for the signs of dehydration, which are danger signs. So increase fluid intake, what you will do, you will give ORS or alternative ORS in the home. What you will give, salted rice water or salted yogurt, or soup with salt, or fresh fruit juice without sugar. No sugar should be added. So you are avoiding packed juice. Packed juice should not be given because it contain added sugar. Fresh fruit juice should be given with no sugar, tender coconut water, and ragi ganji or lassi buttermilk. These can be given instead of ORS. But what is ORS and low molecular weight, low osmolar ORS? We'll see. Glucose and sodium is transported in the same co-transporter. So sodium and glucose should be at the same concentration, 75 milliosmol per liter. Whereas potassium, it's 20 and citrate 10. Half you will do, minus 10 you will do 65. 65, 10, 20 and 10. This is the sodium and glucose should be same concentration, whereas potassium and citrate are half, potassium half is citrate, and then chloride will get 75 minus 10. Totally you will have 245 milliosmol per liter, which is less than 290, which is a blood osmolarity. So blood contains more osmolar, and then this fluid contains less osmolar. When you are drinking, this fluid will be inside the lumen. So water will enter from low osmolar, that is high hydrostatic pressure, to the low hydrostatic pressure. So water will enter from the lumen into the bloodstream. So there won't be watery diarrhea. Did you get it? Then coming for the amount of ORS you should be given. Principle, you have to replace ongoing losses. Dose can be calculated according to the age. Dose can be dose varies according to the age. If it is if they are less than 2 years, 2 to 10 years, or more than 10 years. If they are less than 2 years, you can give for per stool you can give 50 to 100 ml. If they are 2 to 10 years, you can give 100 to 200 ml per stool. Whereas if they are more than 10 years, you can give as much as they need, as much they are desire. So you in this page you learned about the complications. Complications may be convulsions because of these electrolyte imbalance, or metabolic acidosis, infections, or dehydration. Management you are learning plan A and ORS composition, and all those you learned in this page. Now moving on to the other one. continuing the plan A first, you are continuing the like or replacing the ongoing losses. Now you have to continue the feed in order to prevent the malnutrition. Breastfeeding should be continued, it should not be stopped, and you have to give more soft cooled food, cooked food, because digestion will be easier and more nutrients are absorbed easily before diarrhea occurs. You have to give additional meals after every episode of diarrhea, so that they won't go for malnutrition. And you have to watch for the signs of dehydration. It may be because acidosis will cause renal failure and finally death. So these signs are important, which are called as danger signs of dehydration. And this is all about the plan A. Now coming for the plan B. Plan B is given for some dehydration. In some dehydration, ORS is used to correct the dehydration. Indications when we are giving ORS is mild to moderate dehydration or diarrheal diseases, hypovolemia, vomiting, excessive sweating, or inadequate fluid intake. Wherever this fluid is less in our body, we are giving this ORS directly. And in case of some dehydration, we are giving directly plan B instead of home prepared foods or home prepared alternative fluids. When after giving this ORS and all, you have to, after 4 hours, you have to reassess the child for a degree of dehydration, whether this is no dehydration, some dehydration, or severe dehydration. If there is improvement, you have to shift for a plan A from plan B or shifting to plan A. If there is no improvement, you are still staying in the plan B, that is you have to continue the plan B. If there is a severe dehydration, you will shift to plan C. You are in B now. If there is a improvement, you'll go to A. If there's no improvement, it has become severe. If there's no improvement, you'll still stay in the B. If it has become severe dehydration, you'll go shift to the plan C. How low osmolarity ORS will work means it will reduce the stool output, and then it will decrease, if in case of vomiting, it will decrease vomiting. It will reduce the use of IV fluids, as in it increases the blood volume by drawing blood from the lumen, and it will reduces the risk of hyponatremia. In steps what you in plan B, what are the steps you need to do means you have to first rehydrate and then replace, and daily fluid requirement you have to calculate and then provide. In rehydration, you have to provide 75 ml per kg. If the suppose the child is 10 kg, you have to provide 750 ml over 24 hours. Within one day you have to provide within 4 hours. So in 4 hours you have to, for a 10 kg child, in 4 hours you have to provide 750 ml. And second step is replacement. After providing this, you have to replace the ongoing losses. Per stool you will be replacing as per the plan A only, for other fluids, home fluids and all, you will be replacing. And daily fluid requirement is calculated by holiday cigar formula. Holiday cigar formula states that, like, for first 10 kgs you will be giving 100 ml per kg per dose, whereas next 10 kgs you will be giving 50 ml. Next, for the next more than 20 kgs means you will be giving 20 ml. That I will be discussing in the next page. So in this you have learnt about the plan B and how we will follow up, what are the uses of low osmolar ORS, and what are the steps in the plan B you have learnt. Now we'll move on to the holiday cigar formula. According to the weight, you are calculating the dose of daily fluid requirement for the child. For first 10 kgs, you will be giving 100 ml per kg, whereas next 10 kgs, that is 10 to 20 kgs, you will be giving 50 ml additional 50 ml per kg. I'll show with the example. I will teach you how to calculate with the example. More than 20 kgs means you will be giving 20 ml per kg. Suppose you take the child is 26 kgs, so you will divide into 10 plus 10 plus 6. For this 10 kgs 100 ml into 10, whereas for this 10 into 50 ml per next 10 kgs, whereas last 10 kgs it's 20 ml, 6 into 20, so 100, this is 1000, this is 50 into 500 plus 6 into 20, that is 120. So 100 and 1620 is the daily requirement of daily fluid requirement for that child, for 26 kg child. This is how you will calculate using holiday cigar formula daily requirement of the fluid. Next you have Rismol. Rismol is a rehydration solution for malnourished child, where ORS for severely malnourished child you will be giving. So rehydration of solution for malnourished child, you will be giving ORS for in order to rehydrate. It provides so potassium and chloride as well. Though there is a commercially available ORS solution, it can be prepared like these resmol can be prepared by adding like WHO recommended ORS, which I told, low molecular weight low osmolar ORS in a 2 liter of water with 50 grams of sucrose and 40 ml of electrolytes. You will mix and you will get one solution. This is known as Rismol. This solution is administered in a dose of 75 ml per kg. Suppose for over 12 hours. Suppose the child is 10 kgs, you will be administering 750 ml of this solution within 12 hours. This is how. Then I will explain how this low osmolar ORS will work. This is a lumen of GIT, gut lumen. In case of severe diarrhea, so all electrolytes, ion channels and like protein channels will be altered, and all sodium, chloride and everything will be secreted inside the lumen, which will further draw the water inside the lumen and causes watery diarrhea. But when you are giving the low osmolar ORS, like that the glucose and sodium will be transported in the co-transporter, so you will be giving same concentration of these sodium and glucose. Sodium and glucose will be giving same concentrated, so sodium is drawn back into the blood along with the glucose, so the sodium is replenished, but this chloride and all will be lost. When the blood osmolarity is more and this gut lumen osmolarity is less, blood osmolarity is 290 milliosmol per liter, whereas lumen osmolarity is 245 milliosmol per liter. So the air fluid will be more, so fluid moves from high pressure to the low pressure, so more fluid, more pressure from ear to the ear, so fluid is going back into the bloodstream, so you are preventing the watery diarrhea. This is how the mechanism of the low osmolar is. So now they are replaced by the low osmolar ORS. See in case of diarrhea, like gut lumen is there, sodium and chloride is secreted into the lumen, glucose and sodium is reuptaken, so sodium is replenished, whereas blood osmolarity is 290 milliosmol per liter, which should not be replaced by it should be replaced, which should not exceed 290 milliosmol, because it causes low osmolarity and it further draws the water into the gut lumen and causes it worsen the conditions. So low osmolarity in the gut lumen will causes more absorption of fluid into the bloodstream. So low osmolar ORS is used all over the world according to WHO, which is 245 milliosmol per liter. Now coming for the plan C, which is for severe dehydration, you will use Hartmann solution, which is where the child won't be active enough to drink the fluids which are given orally, so you will directly go for IV fluids. Ringer lactate and 5% dextrose you will inject, which supplies adequate concentration. In ringer lactate you will have electrolytes, sodium, potassium and lactate is supplied, and bicarbonate is also supplied, which will prevent acidosis, and 5% dextrose for the energy. So rehydration I will do, you will give 10 ml 100 ml per kg replacement should be done. You will divide it into first 30 ml and next 70 ml. If the child is less than 1 year, you have to give for a long time. You should not give as a bolus, you should not pull it as a bolus. So if the child is less than 1 year, you will be giving for a prolonged time, slowly you will be giving 1 hour you will take, whereas if child is more than 1 year, you will give within half of this time, that is 30 minutes for 10 ml 30 ml per kg, whereas for 70 ml per kg, if the child is less than 1 year, you will give for 5 hours, whereas more than you will reduce the time, more than 1 year you will reduce the time. So overall time 1 plus 5 is 6 hours, whereas 30 minutes plus 2.5 hours is 3 hours. This is about the plants. We learnt about the reosmolar and holiday cigar formula, and how the mechanism, how it will prevent dehydration, low osmolar WHO recommend low osmolar ORS, and you also studied about the plan C rehydration thing. And now coming for the In a plan C, you will also give zinc therapy. Zinc should be given for 14 days. And role of zinc is it will the GIT, all this will be like eroded. GIT, so epithelium will be eroded, so it will re-epithelize the re-epithelialization of the gut epithelium, and then it will decrease the risk of persistent diarrhea. And what is the dose of zinc given is less than, for 6 months means you will give 10 milligrams, more than 6 months means you will give 20 milligrams. And additional drugs which are given for a diarrhea is antibacterial. If the cause is infectious cause, it will treat it. Third generation cephalosporins is given, doxycycline and ciprofloxacin is given. If it is a protozoal causes protozoal, you will give metronidazole. And you will see if there is vomiting also, because of vomiting dehydration is there, you will give antiemetics. Antiemetics is ondansetron, per dose is 0.15 mg per kg per dose orally you will give ondansetron. And you will also give probiotics in order to prevent vomiting. You will give probiotics which causes the movement downwards, and then it won't be reflex back. So you will prescribe probiotics according to the cost benefit analysis, which is the best for that cost. You will give example, like lactobacillus, rhamnosus and Saccharomyces boulardii. These are the two probiotics you will prescribe. These are like additional drugs to be prescribed are antibacterial, antiprotozoal for vomiting, antiemetics and probiotics. And zinc dosage and zinc role of zinc in dehydration you have studied. Now coming for the prevention of diarrhea, how we will prevent means, diarrhea I already told the route of transmission is a fecal-oral route through food and water, so you have to maintain the sanitary food and water. And then excessive blood feeding, so which provide immunity through IgA antibody, it will provide immunity. And then you have to clean water daily, so water and food should be hygiene. Hand washing, repeated hand washing. Sanitary, you have to use sanitary latrines because it is transmission through fecal-oral route. Safe disposal of stools. And you have to, measles also will causes chronic diarrhea, so you have to prevent measles by measles vaccination. Now reduced osmolarity, that already I told, but this is in milligrams. This concentration in milligrams. This you need to mug up. If you can remember this, or else this is not required. Now moving on. Moving on, we have studied like initially what are the this is a major contribution for the death under 5 mortality. How we will classify the diarrhea and the definition of diarrhea and dysentery. Etiology causes may be infectious causes and non-infectious causes. What are the risk factors for acute diarrhea? Then pathogenesis of diarrhea, clinical features of diarrhea, and how we will assess the degree of dehydration in case of acute diarrhea. And then the treatment, like you have studied the complications of the diarrhea, then flu, what are the alternatives that can be given instead of ORS, and low osmolar ORS and uses of low osmolar ORS. In management you studied type A, type B and type in management you have studied type A, type B and type C. Plan A, plan B and plan C for no dehydration, some dehydration and severe dehydration. And you have already also studied the holiday cigar formula. And you have studied how we will follow up, and what are the uses of zinc dose therapy and other complications, other drugs to be given, and how we will prevent diarrhea. This is all you study. If you find this video helpful, please do like, share, subscribe to the channel. If you have any suggestions, let me know in the comment section. Thank you.